Welcome to the Deep Dive. Today, we're doing a full immersion into the world of orthopedics,
We certainly are.
specifically the total knee arthroplasty. As a resident, I'm just constantly amazed at how we move beyond just, fixing a problem and try to engineer a replacement that actually mimics human biology. We are talking about the subtle science of movement and force, the stuff that separates a good knee from a great knee.
It's really the difference between stability and true function. We're moving past the early days of TKA where, success was defined solely by component survival.
Right.
And now we're relentlessly pursuing the replication of the natural knee's performance. For you, the listener, and for us in the clinic, the challenge is clear. The knee is the largest and, well, arguably the most complex joint in the human body.
And the need is only growing. The clinical imperative is just huge.
Oh, absolutely.
We see high-energy sports trauma in younger patients, which inevitably causes microinstability and cartilage breakdown that just exacerbates degeneration decades later.
And then you layer on the other side of things.
Then you layer on the sheer volume of primary osteoarthritis and rheumatoid arthritis in our aging population. When that joint collapses, TKA is often the only pathway back to true function.
Total knee arthroplasty is perhaps the most refined piece of restorative engineering we perform. But here's the massive challenge that really underpins our deep dive today.
Okay.
Variety. You walk into any major hospital and you realize there are currently well over 150 unique TKA designs commercially available globally.
That's a staggering number.
It is.
And as surgeons, we have to make decisions based on these blueprints, which vary primarily across, 4 crucial dimensions?
That's right. The geometry of the condyle surfaces, the mobility of the bearing, whether it's fixed or allowed to slide and rotate,
Okay.
the method of ligament management, and of course the technique we use for fixation.
Absolutely. The stakes are immense.
They are.
Evaluating the performance of these 150-plus designs in vivo has to be the biggest hurdle in modern orthopedics.
It really is. We can test them rigorously in cadavers, but, cadaveric models fail to replicate the complex muscle activation, the soft tissue tensioning, and all the resultant forces you see in a living, weight-bearing patient.
And that brings us right to the core mission here.
Yeah.
How do we, non-invasively, assess whether a specific implant design is failing to track correctly years before the patient feels catastrophic pain?
It's the key question.
Because standard imaging X-rays, CT, even MRI, can only pick up gross injuries, right? Gross component migration or severe osteolysis.
They miss the subtle stuff.
They miss the early wear, the subtle maltracking, the very things that guarantee a failure 5 years down the line.
So our mission today is to evaluate the cutting-edge methods that are bridging this gap. We need to measure performance dynamically in real time during activities of daily living.
So we're focusing on the 3 pillars of dynamic performance assessment. First, we delve into knee kinematics, the study of pure motion and geometry. Second, knee kinetics, which analyzes the forces, the loads, and the torques the joint experiences.
And finally,
the disruptive, non-invasive future of diagnosis, vibrational signal analysis, or vibroarthrography,
Right.
basically the science of listening to the joint.
kinematics is the starting line. I mean, if we can't replicate the geometry of natural motion, everything else, load distribution, soft tissue balance, it's all going to fail.
Okay, so to determine that pure motion, the historical gold standards were, they sound brutally invasive. We're talking about techniques that are highly accurate but just completely impractical for routine follow-up.
Oh, they were.
Can you describe just briefly what methods like cortical pins or Roentgen stereo photogrammetric analysis, RSA, actually involve?
For sure. In the early days, and, still for very specific research applications, we had to attach things directly to the bone.
Wow.
Cortical pins are essentially markers temporarily drilled right into the outer surface of the femur and tibia to track their relative positions during motion.
Grilled in.
And RSA is similar, but it involves implanting tiny metallic tantalum beads into the bone, right near the components. By taking simultaneous X-rays from different angles, we can precisely calculate the 3D movement of those beads and thus the components.
That sounds like a whole other surgical procedure just to measure motion. Obviously, that's not something we can ask every patient to undergo in the clinic.
Exactly. So necessity bred innovation. Our primary non-invasive tool now, which has largely replaced the invasiveness of RSA for component tracking, is fluoroscopy-based model reconstruction.
Okay.
It's brilliant, really. We take dynamic, two-dimensional X-ray video as the patient performs an activity, say, a deep squat.
Right.
Then we take the known 3D computer models of the components themselves, the tibial tray and the femoral component, and we mathematically register those 3D models to the 2D images.
So it's almost like you're reverse engineering the motion. You know what the pieces look like, so you use the flat image to figure out where they have to be in 3D space.
That's it.
And that gives you highly accurate data on exactly how the components are moving against each other.
Precisely. It allows us to track pure kinematics without ever cutting the patient or introducing markers.
So what is the motion we're actually aiming for? What does the natural knee do that makes it so successful?
The hallmark is the screw-home mechanism. As you move from flexion into full extension, the tibia externally rotates relative to the femur.
Okay.
But the mechanism that creates this is the asymmetrical movement of the condyles. Crucially, the lateral condyle experiences substantially more posterior motion or rollback than the medial condyle throughout flexion.
I see.
That difference in rollback is what creates stability and maximizes the leverage for the muscles. Post-TKA, replicating this depends entirely on the component's condylar geometry and, frankly, the sheer surgical accuracy of alignment.
Yet we know that TKA, despite our best efforts, often fails to perfectly replicate this really elegant motion. Fluoroscopic studies like the seminal work by Dennis and his group have consistently documented kinematic variances.
They absolutely have. The knee post-TKA, it just becomes less predictable. And the most documented and, well, notorious anomaly is paradoxical anterior femoral translation.
Ah, the anti-roll mechanism. It sounds like the implant is intentionally trying to frustrate us.
It is. I mean, think about what's supposed to happen. To increase your range of motion during deep flexion, the femoral component is meant to roll and slide posteriorly along the tibial-bearing surface.
Right.
Paradoxical translation is when, instead of tucking posteriorly, the femoral component slides anteriorly on the polyethylene surface during deep flexion.
So it's like trying to navigate a narrow corridor, but the door keeps swinging into your face instead of tucking away.
That's a perfect way to put it. Now, let's detail why this is so detrimental. This isn't just some quirky motion. It's a precursor to failure.
Right.
What are the technical consequences of that anterior slide?
Well, first, the biomechanical change. It causes the anteriorization of the flexion axis. This is where the concept gets a little dense. The axis of rotation of the knee shifts too far forward.
And if that axis shifts anteriorly, it has these cascading effects.
Right.
We're losing the mechanical advantage. That reduced distance means you are reducing the quadriceps moment arm.
Which means the quadriceps muscle loses its leverage. The patient has to activate the quads harder, expending more energy just to achieve the same amount of extension.
Yep.
And that contributes to that post-TKA sensation of weakness or instability during activities like climbing stairs.
Exactly. Secondly, this anterior position increases the risk of posterior impingement. Now you have the back edge of the femoral component or the posterior soft tissues, the papsule, sometimes the PCL remnant being pinched because the femur hasn't rolled back out of the way.
And the third consequence, and this is related directly to the implant longevity, accelerated polyethylene wear.
Mm-hmm.
If the femur keeps sliding back and forth across the same small area of the tibial bearing, rather than utilizing the full excursion of the component surface, you're creating highly localized, repetitive stress.
That highly localized grinding just drastically shortens the life of the polyethylene. Now, let's discuss another anomaly Dennis documented: reverse axial rotation. We established that the normal knee externally rotates as it extends. What happens when the TKA component rotates the opposite way during flexion?
That reverse rotation is just trouble for the patellofemoral joint.
Yeah.
It tends to happen because the soft tissue envelope is trying to guide the rotation, but the implant geometry is fighting it.
Right.
And this unwanted motion increases the Q angle during deep flexion.
For our listeners who may not recall the exact anatomical definition, the Q angle or quadriceps angle is the angle formed by a line drawn from the anterior superior iliac spine to the center of the patella, and a second line from the center of the patella to the center of the tibial tubercle. So if that angle increases too much, what are we risking?
By increasing the Q angle, you're essentially pulling the line of force further laterally. We unnecessarily lateralize the tibial tubercle relative to the femur during motion.
Yeah.
And this significantly increases the risk of patellofemoral instability, meaning the patella is more likely to maltrack or tilt or even subluxate out of its groove. It's a kinematic ripple effect, starting with rotation and ending with patellar pain.
And the most tangible result for the patient, reduced flexion.
Yeah.
Dennis's work showed clearly that reduced posterior femoral rollback, specifically in the lateral femoral condyle, which is supposed to do the bulk of the rolling, is directly correlated with reduced maximum knee flexion.
You just run out of track space.
You run out of track space, and the patient simply cannot squat or kneel as deeply.
These kinematic flaws lead us directly to the great orthopedic debates, what you aptly call the design wars. It starts with bearing mobility, fixed versus mobile.
Mm-hmm.
As a resident, the rationale for mobile bearings always seems intuitively superior. Reduced contact stress, less wear, and theoretically a better chance of recreating that elusive natural knee kinematic pattern.
That's the ideal theory. And let's be fair, in vitro studies, lab studies where conditions are perfectly controlled, they often supported this. Fisher and his group showed reduced contact stress and reduced wear rates for mobile bearings compared to fixed.
But the lab is not the patient.
The lab is not the patient. Here's where the data diverges. When we look at the clinical reality, the in vivo metrics over years, the kinematics, the patient-reported outcomes, and the long-term survivability for fixed and mobile bearing implants have produced remarkably similar results.
They really have.
It's a humbling reality check for the engineers. The mobility of the insert doesn't seem to translate into a measurably superior outcome in large patient populations. Post et al., in a comprehensive study, concluded there was no compelling basis to clinically justify the selection of one design over the other based on survival or function alone.
So we have a component that's more technically complex, often more expensive, and requires a slightly different surgical technique, but it offers no proven functional or longevity benefit over a well-implanted fixed bearing.
That's the consensus among many surgeons. Post et al. Concluded that the paramount factor for success isn't the component type, but the surgeon's consistency and accuracy during implantation. They found that if a surgeon is comfortable and can consistently achieve perfect alignment with a fixed bearing, the results are likely just as good as a perfectly aligned mobile bearing.
And what about on the same patient?
Furthermore, Kim et al. Studied fixed and mobile configurations in the same patient, one of each type, and still found no significant difference in range of motion or clinical knee scores.
So if bearing mobility is basically a wash, let's pivot to ligament management. Cruciate retaining, or CR, versus posterior stabilized, or PS. We established that CR designs, which leave the PCL intact, are often the ones exhibiting that problematic, paradoxical anterior femoral sliding.
That's right. The anterior displacement happens because the PCL tension often fails to pull the femur back adequately in early to mid-flexion. The posterior stabilized, or PS design, was specifically engineered to overcome this. By removing the PCL, the PS design introduces a mechanical substitute, the cam post mechanism.
So the cam and the femoral component hits the post on the tibial insert, and it physically forces the femur to roll posteriorly, thus eliminating the anterior sliding.
Correct.
That sounds like a clear win for kinematics and range of motion.
It is, in terms of achieving posterior rollback. But this is where the controversy lies. CR proponents who prefer saving the PCL argue that the PFR seen in PS knees isn't natural. It's a guided motion dictated purely by hardware interaction. They argue this mechanical guidance generates high localized stresses.
I see.
Bourne and Barre provided the strong critique that this mechanical forcing potentially leads to higher rates of failure, specifically due to cam post wear or fracture over time.
This is a perfect example of where we need to dive into the fluoroscopic data to really understand the mechanics. Let's compare the dynamic interaction between the cam and post in a fixed bearing design versus a mobile bearing design during a strenuous activity like a deep knee bend.
Excellent. Researchers use dynamic fluoroscopy to track the interaction in fixed-bearing BCS, that's bicruciate stabilizing designs, against high-flexion mobile-bearing PS designs.
Okay, let's look first at the fixed-bearing BCS. What did the dynamic X-ray show about when and how the cam hit the post?
What they saw was extreme variability. While the mechanism is designed to engage deeper in flexion, the average engagement was around 34 degrees of flexion.
That's quite early.
It is. And crucially, the range was enormous. Some patients engaged at 15 degrees, others not until 68 degrees.
Wow.
That kind of inconsistency patient to patient is terrifying for long-term predictability.
A 53-degree spread in engagement timing. That suggests the soft tissue tension, or the alignment, is overpowering the component geometry early in the flexion cycle.
And that's not even the main problem. The contact pattern itself was unstable.
How so?
For most subjects, the initial contact occurred on the tibial post medially and only gradually moved toward the center as flexion deepened. This leads directly to the core failure mechanism, edge loading.
Edge loading. So the contact stress is focused intensely on a small, weak point of the polyethylene post.
Precisely. If the fixed-bearing femoral component undergoes even subtle external rotation during motion, which is a common kinematic variance, that rotation forces the cam to hit the post significantly off-center, increasing the load exponentially on the edge of the polyethylene.
It's like trying to hit a nail with the corner of a hammer instead of the flat face.
Exactly. It guarantees localized stress and subsequent material fatigue and failure.
So the fixed geometry, combined with even subtle rotational kinematics, creates this high stress point that works against the survivability of the polyethylene. That's a structural time bomb.
It is. Now contrast that with the mobile bearing PS design. When researchers observed these components, the cam-post interaction was highly consistent. The engagement was much deeper, occurring predictably between 90 and 105 degrees of flexion across all subjects.
A much tighter window. That indicates reliable, reproducible performance.
Yeah.
So why is the mobile design suddenly superior here, when earlier we established that mobility didn't necessarily improve outcomes generally?
The mobility solves a specific kinematic problem, rotation. Because the polyethylene insert is free to rotate axially on the metal tibial tray, the insert itself self-adjusts to the femoral component's rotation. This ensures that the posterior surface of the mobile-bearing post remains consistently parallel to the surface of the femoral cam, regardless of the knee's axial rotation.
That's fascinating. So the mobile bearing doesn't eliminate the rotation, but it accommodates it, ensuring the contact point remains central and parallel at all times, distributing the load correctly.
Exactly. This central contact drastically minimizes asymmetrical loading conditions and prevents that devastating edge loading we see in the fixed-bearing designs.
Right.
And this synthesis of dynamic data provides powerful evidence suggesting why mobile-bearing PS designs might, counterintuitively, have a long-term survivability advantage over fixed-bearing PS designs.
Because it reduces the wear on the cam post?
Exactly. It validates the concerns raised by Bourne and Bure.
This illustrates perfectly why we can't just lump all PS or all mobile-bearing components together. The combination of features is what matters.
Which, moving from the general design types, we have to briefly touch upon the emerging solution to kinematic replication: personalized TKAs.
This is the ultimate attempt to solve the geometry problem, right?
Yeah.
By trying to perfectly match the patient's pre-arthritic features.
Yes. The underlying principle, championed by researchers like Palumbo and Fitz, is that native anatomy is best. Why try to fit a uniform, mass-produced femoral condyle onto a patient whose unique bone geometry has evolved over decades?
So how does it work?
Personalized TKAs utilize preoperative CT or MRI scans to generate a precise 3D model of the patient's distal femur and proximal tibia.
And then what happens? Do they 3D print the component itself or just the surgical guides?
Usually, they create custom, patient-specific cutting guides using 3D printing. These guides are designed to fit the precise contours of the patient's bone surfaces, ensuring the bone cuts are made to replicate the native mechanical axis and joint line position as closely as possible.
So it's not about designing a radically new implant material. It's about making sure the bone is cut precisely to accept the implant in the exact location that minimizes kinematic disruption.
Correct. The goal is to restore the patient's individual joint geometry and soft tissue envelope tensions.
And the results?
Early results are very promising. Studies show these implants exhibit kinematics that are much closer to the normal knee than off-the-shelf components. The challenge now is, scaling up cost-effectiveness and getting long-term survivability data to see if this superior kinematic replication translates into superior 10 or 15-year outcomes.
Shifting gears from the study of pure motion kinematics to the study of force kinetics. This is where we understand the immense engineering burden placed on these metal and plastic interfaces. What are the key objectives when we try to determine in vivo forces and torques?
We aim for 3 critical deliverables from kinetic data. First, and immediately, it allows engineers to predict the long-term performance and potential failure points of new implant designs before they ever enter a patient.
Okay.
Second, it guides us in simulating surgical procedures, allowing us to tweak alignment or soft tissue tensioning in a virtual environment to optimize outcomes.
And the third objective is broader, right? It
Yeah.
addresses the origin of the problem itself.
Exactly. We use these load mechanics to investigate the root causes contributing to degenerative joint disease. Understanding how load is distributed in a healthy joint or an early arthritic one can tell us where we need to intervene to prevent TKA altogether.
So how do we get that force data? You mentioned the gold standard is highly accurate, but logistically intimidating.
We use telemetry, which relies on instrumented implants. Imagine a TKA component, a tibial tray or femoral component that has been embedded with miniaturized sensors and a telemetric chip that can transmit data wirelessly in real time.
Wow.
These custom-made implants report resultant forces and torques in all 6 degrees of freedom. It's the closest we get to ground truth.
That's incredible.
Uh,
But because these implants are custom, the patient groups have to be tiny. So what have we learned from the select group of patients who have received these highly instrumented knees?
The data, primarily from groups like DeLima et al., has provided landmark findings on load magnitude during daily activities. It completely reshaped our understanding of activity demand. For high-load activities, the lunge, for example, generates peak forces ranging astonishingly from 1.7 to 2.77 times body weight, or BW.
Nearly 3 times the patient's body weight on a single joint during a controlled movement. What about simple activities?
Even level walking generates significant forces, typically ranging between 1.8 and 2.5 times BW. It confirms that the knee joint is a highly stressed structure, even in routine life.
And what about exercise choices? What can we tell patients based on this kinetic data?
We learn that machines can be deceptively demanding. The elliptical trainer, often recommended as low impact, was found to be highly strenuous, generating a mean peak tibial force of 2.24 times BW.
That's surprising.
It is. In stark contrast, bicycling was the lowest load activity studied, peaking at only 1.03 times BW. That specific data point, that bicycling subjects the knee to roughly body weight and force, is critical for post-operative rehabilitation planning.
Beyond sheer magnitude, the crucial kinetic insight is load distribution. Is the force symmetric between the medial and lateral condyles?
And the answer is maddeningly, it depends on the activity.
Of course it does.
During the lunge, the force distribution was found to be nearly equal. However, during the chair rising activity, a very common, high-demand functional movement, the distribution became highly asymmetrical. The lateral condyle consistently experienced the highest force ratio, accounting for a massive 61.7% to 74.2% of the total resultant force.
That is a huge disparity. The lateral side is carrying 3/4 of the load during sit-to-stand.
Yeah.
That must be a major input for implant design.
It is. But as you noted, telemetry is restricted to small patient groups and only tells us about implanted knees.
Right.
It can't analyze a healthy knee or an early arthritic knee on a large scale.
And that is the gap that mathematical modeling steps in to fill, offering a theoretical alternative to calculate joint forces in non-implanted or larger patient populations.
Right. Modeling uses 2 main strategies: optimization techniques to guess indeterminate muscle forces, or reduction methods that simplify the system based on known biomechanical principles. Comestek et al., using a reduction technique based on Kane's method, estimated maximum forces in a healthy knee during walking at 1.7 to 2.3 times BW.
So how reliable are these mathematical models when we compare them against the gold standard telemetric data?
They're surprisingly robust. Sharma et al. Compared their modeling against a fixed-bearing telemetric implant. The model predicted forces of 1.89 times BW on the medial side and 2.05 times BW on the lateral side.
Okay.
The actual holometric measurements were 1.9 times BW and 2.2 times BW, so the model was within 10% accuracy, confirming its utility for reliable estimates where telemetry is not feasible.
This modeling approach also allowed Sharma and his group to directly compare the kinetics of fixed versus mobile-bearing implants during the high-demand deep knee bend activity. What was the critical finding regarding force distribution here?
First, the model showed that the total tibiofemoral forces for both fixed and mobile implants were similar in magnitude during DKB. But the critical finding regarding distribution was a complete reversal of the chair rise data.
Okay.
The medial condyle always had substantially higher forces than the lateral condyle during the deep knee bend.
Wait, let's stop and challenge this data, because this is a significant conflict. DeLima's telemetric data showed the lateral side taking the lion's share of the load during chair rising, often over 70% of the force. Now, Sharma's modeling shows the medial side is absolutely dominant during deep flexion, carrying up to 2.73 times BW.
It's not a conflict, but a crucial clinical distinction. It tells us that load asymmetry varies wildly, depending on the specific activity and the degree of flexion.
Well, I see.
Chair rising involves low flexion angles but high muscle stabilization, which loads the lateral side heavily. Deep knee bend, however, pushes the knee into maximum flexion, and in this position, the load asymmetry is severe.
How severe?
Extremely severe. The medial force reached up to 2.73 times BW at full flexion for both designs. Conversely, the lateral condyle force consistently stayed below 1.09 times BW than the body's weight for both fixed and mobile designs.
The implication for design is immense. The medial compartment is the structural workhorse during deep flexion, handling 3 times the force the lateral side does. As surgeons, what do we take away from that kind of disparity?
It confirms that we must design the medial tibial plateau for maximum endurance. That means focusing on the material integrity, thickness, and sterilization methods of the polyethylene on the medial side. The medial polyethylene is working 3 times harder in a DKB.
So if there's any defect.
If there is a slight defect, or if material degrades due to oxidation or other factors, that medial component is going to fail first. We need to focus our material science efforts directly on that medial zone to manage up to 2.73 times BW stress consistently.
If kinematics and kinetics tell us how and how hard the joint is working, we now transition to the future of non-invasive diagnosis. The ability to listen to the joint to detect pathology before it becomes catastrophic.
Right.
This is vibroarthrography or VAG.
This field is incredibly exciting because it connects state-of-the-art signal processing with a concept that dates back well over a century. Hayter, way back in 1885, linked specific sounds emitted by the knee joint to pathology. And in 1913, Bircher suggested that specific types of meniscal injury emitted a distinctive sound signature.
That's amazing. They were trying to use sound as a diagnostic tool decades before we had X-rays.
They were.
And Walters, in 1929, performed a huge study on 1,600 knee joints, where he noted a steadily ascending ratio of audibility moving from a smooth sound to a rough sound and eventually to a grating sound as patients increased in age.
And he hypothesized a direct link.
He hypothesized that this sound profile was directly related to the progressive breakdown of the joint's condition.
The initial challenge was just the technology. Early researchers used rudimentary tools like cardiophones and standard stethoscopes. Spangler, in 1937, tried to use acoustic filtering to remove ambient noise and correlate the residual joint sounds with pathology confirmed in the operating room. But the data was messy.
Sure.
Palin, in the 1950s, tried to use electronic stethoscopes to distinguish between different types of arthritis, but that effort was largely abandoned due to a high noise-to-signal ratio.
The technological breakthrough came when the modality shifted from sound transmission microphones to force detection accelerometers. Mullen and his group pioneered this shift in the 1980s.
That was the crucial step. Microphones pick up everything, including ambient noise and, critically, skin movement artifact. When the skin moves over the joint, it generates its own noise that masks the subtle internal joint sounds.
Right.
By using miniature accelerometers, which are secured tightly to the bone prominences like the femoral epicondyle or tibial plateau, we reduce both ambient noise and the skin artifact dramatically. We get a much cleaner, verifiable signal.
So once you have that pristine vibration signal, how do you process it to make a diagnosis? You can't just listen to the raw noise.
No, we use advanced signal processing, and the current state-of-the-art is the wavelet transform. This is a massive improvement over older Fourier analysis.
Oh.
Think of Fourier analysis as identifying only what frequency a sound occurred at. The wavelet transform is far more powerful. It allows researchers to characterize the signal simultaneously in both the time domain and the frequency domain. Essentially, it tells us not just what type of vibration we're hearing, but exactly when it happens within the gait cycle or the flexion-extension arc.
I see.
And this is essential because kinematic patterns, like the onset of femoral liftoff, can be used as context aids to classify the corresponding sound signal.
That makes the data actionable. We can pinpoint the exact moment of dysfunction. Now, if we want to move this into a resident's hands or automate diagnosis in a large clinic, we need pattern recognition. We can't rely on years of surgical experience listening to thousands of knees.
And that's where machine learning takes over. We first extract feature vectors from the raw signal. These are statistical parameters, the mean, the deviation, the kurtosis, the quantiles, that numerically define the characteristics of the vibration signal.
And then the machine learns.
Exactly. We use supervised learning methods, often neural networks, which compare these extracted numerical features against massive databases of known outcomes, confirmed cases of arthritis, ligament tears, or well-functioning TKAs.
I see.
The algorithm then learns to predict the likelihood of a specific pathology based on the feature vector it receives. Umapathy and Krishnan, for example, used wavelet packet decomposition coupled with a local determinant-based algorithm to identify the highly discriminatory basis functions necessary for accurate classification.
What kind of accuracy are we currently achieving with this automated system?
Right now, these pattern recognition techniques have diagnostic accuracies ranging from 85% to 91% when classifying a knee condition as simply normal versus arthritic.
Okay.
That's comparable to results reported by groups like Rangayan and Wu.
90% accuracy for detecting gross arthritis is great. But if VAG is going to be the revolutionary tool we hope for, we need specificity. It must move beyond your knee is generally bad to your lateral meniscus is torn.
That's the major clinical challenge and the focus of current research. We need to isolate specific soft tissue pathologies. We need AGAG to differentiate a ligament rupture from a meniscal injury, or to identify subtle patella maltracking from simple osteochondral wear.
Right.
If it can't isolate the distinct vibration frequencies unique to each damage condition, it won't replace existing, highly specific imaging modalities like MRI.
But the early visual data is highly suggestive that this specificity is possible.
Yeah.
Let's talk about how researchers illustrate the differences between a healthy knee and a failed implant.
When researchers visualize the vibroorthograms, they see clear, distinct patterns. For example, the trace of a healthy knee is relatively smooth and predictable, with low amplitude vibrations concentrated in specific frequencies related to gait.
Okay.
An arthritic knee, however, shows much higher amplitude vibrations across a broader frequency spectrum. That's the rough or grating sound Walters heard a century ago.
Sure.
And crucially, the pattern for a well-functioning TKA is different again, reflecting the smooth motion of the polyethylene.
And a failed TKA.
A failed TKA, perhaps due to cam post wear or aseptic loosening, displays distinct chaotic spikes in the vibration signature, reflecting mechanical instability or component-on-component grinding. The magnitude and variation in specific frequencies are measurably distinct between a well-fixed knee and one that is failing.
And the most promising research hints at the ability to not just detect damage, but to localize it, which is the holy grail for a non-invasive tool.
That's right. Researchers examined patients who had surgeon-reported unicompartmental damage, meaning the damage was confined primarily to the medial or lateral side, as documented during their surgery. They then placed separate accelerometers simultaneously on both the medial and lateral femoral epicondyles pre-surgery.
What was the finding when they analyzed the signals from those two sensors?
When the damage was isolated, the filtered vibration signals from the medial and lateral accelerometers were measurably dissimilar. For instance, if the patient had primarily medial damage, the vibration profile captured by the medial sensor was chaotic and high energy, while the lateral sensor recorded a profile closer to a healthy knee.
And vice versa, I assume.
Conversely, in patients with lateral damage, the lateral sensor showed the high-energy dysfunctional signature.
That is huge. It strongly suggests the possibility of using VAG to non-invasively map the location of joint damage.
It does.
We could potentially detect subtle early-stage meniscal degeneration on the lateral side simply by comparing the vibration profile of the two sides during gait without needing an MRI.
The potential applications are staggering. Correlating these sound signals with precise mechanical events like condylar liftoff, cam post engagement, or even subtle ligament laxity. This means we are moving toward a world where the diagnosis is instantaneous, non-invasive, and objective.
Okay, let's bring this all together. We started with the sheer complexity of total knee arthroplasty design and the struggle to replicate normal kinematics, that elegant screw-home mechanism, which often fails due to pitfalls like paradoxical anterior translation, especially in fixed-bearing designs.
We then established that the failure modes in kinematics led directly to solutions in the design wars, showing how mobile-bearing PS components can reduce asymmetrical wear by accommodating rotation, providing superior central contact compared to their fixed-bearing counterparts.
We then explored the critical field of kinetics, where real-time telemetry and mathematical modeling confirmed the massive loads the knee sustains, up to 2.77 times BIW, and, critically, revealed the highly variable load asymmetry, with the medial compartment carrying the severe majority of the force during deep flexion.
And finally, we discussed VAG, the emerging field that transforms old-school auscultation into modern automated signal analysis. It's a non-invasive tool already hitting 90% accuracy for gross arthritis and shows huge potential in localizing specific damage based on distinct vibration signatures.
So if we look at this clinically, the connection is indisputable. Understanding the kinetic demands, the fact that the medial side takes the dominant load in flexion, is what drives material science and thickness requirements in our implant designs.
But the ability to diagnose subtle early-stage pathology non-invasively via VAG is the true key to expanding the orthopedic toolkit before surgery becomes mandatory. If we can detect cartilage breakdown or subclinical component wear years earlier than an X-ray can, we open the door to regenerative medicine or targeted, minimally invasive interventions that might stall the progression to total knee replacement.
This leaves us with the ultimate provocative thought for you to consider, based on the convergence of these technical advances. If personalized TKA designs, guided by kinetic data, perfectly replicate normal motion and drastically reduce component wear over the long term, and if VAG becomes accurate and specific enough to detect minute damage, a small meniscus tear or cartilage fissuring, before it's even visible on an X-ray.
Could we ultimately phase out the need for total knee arthroplasty as we know it today? If we can treat mechanical problems and address degenerative disease progression at such an early, precise stage, using non-operative or minimally invasive interventions, perhaps our patients will never progress to the point of needing a massive metallic replacement. That is the goal of every surgeon, pushing the need for replacement surgery further and further into the future,